and welcome to Sage's Stories. I'm Brant Oelschlager, and I would like to thank Dr. Schweisberg and his group for the invitation to share my story today. I regret not being there in person. All of us in Seattle and the University of Washington feel like we've been battling this pandemic since day one, and my colleagues are still not comfortable with us traveling to Las Vegas. I hope this format does not detract from my message. This talk is very personal and is directed at the younger members of the audience primarily. It's a story about surgeons, especially those like us, drawn to SAGES for its embrace of technology and surgical advancement. It's a story about some of innovation's darker, less talked about side, specifically the ignorance of long-term outcomes and personal conflict of interest, not just the industry conflict we often discuss and write on a slide, but the self-interest we often bring to our mutual decision-making with patients. SAGES is a place for new and exciting advances in surgery, and that is the same thing to be celebrated and pursued. Many patients have been helped by the innovations created and fostered in this organization, yet there is another side to innovation. Patients regularly deceived and even harmed. And my message today is a plea to pay attention to both. Maybe it will prove thought-provoking. If not, at least it will be cathartic for me. When SAGES asked me to do this talk, the subject they provided brought this conflict into my frontal cortex. The case is a 50-year-old woman, we'll call her Mary, who is 7 years status post sleeve gastrectomy for weight loss. Mary had a history of GERD and Barrett's esophagus, which was non-dysplastic at the time of her sleeve, and now presents with a nodule within a 3-centimeter segment of Barrett's. This talk is about how this patient is managed, which I will get to. I want to start first with a story. It's a story of my youth, or at least a younger me. I was a 4th-year resident at Harborview, our trauma hospital. The MICU called us one day for a consult on a cerebral palsy patient with aspiration pneumonia. And the question was whether a fundoplication was indicated. I've always been fascinated with the foregut, so I took a particular interest in seeing this patient. My trauma attending was skeptical. The patient was sick, and there were a few confirmatory studies that could be done in this ventilated patient, but I was undeterred. The attending said he only knew how to do an open Nissen, which fueled me even more. It was 1998, and Dr. Pellegrini had been our chair for 5 years. I was never going to do an open Nissen. Eventually, I wore my attending down, and we took the patient to the operating room and did the Nissen. An hour and a half of glory. I saw the patient for a few days, as I recall, far fewer than I did pre-op. Then I signed off as there were no signs of surgical complications. I then remember being copied on her death summary about a month later. What had I done? How had I helped her? Clearly, I had helped myself. I think about her all the time to this day. I've probably seen about 100 patients for aspiration pneumonia since. I'm not sure I've operated on a single one, at least as the primary indication. During residency, and even as a young attending, I remember being hungry for cases. How else could I learn this craft? I had to build a referral network. As I reflect, was it about me or the patient? I'm sure there was a conflict of interest on many occasions. I also remember being primarily concerned with getting the patient out of the hospital without complications. I do not remember thinking as much about the long-term ramifications of the operations I performed. We as surgeons are intrinsically affected more by our patients' short-term outcomes than those years later. This organization was built on the back of less invasive ways of helping people, so please don't misconstrue my message today. I am an advocate for advancement, but the easy part is adopting something new and following the short-term outcomes Because even patients find innovation appealing, we must make sure that we are doing the right thing for the life of our patients and not just the perioperative period. So let's get back to our patient. So 7 years ago, Mary had a history of GERD, but it was well controlled on PPIs. The surgeon she saw was 5 years out of fellowship, had trained to do bypasses, bands, and sleeves. Her 3-surgeon practice did about 90% sleeves, and they were part owners of an outpatient surgery center. And their patients were very accommodating to the least invasive approach possible. When I asked Mary about her recollections of the discussion, she recalled that bypass was brought up as an option, but she had a friend who got a sleeve at the same center, and everything seemed to affirm that this was the way to go. The website, the office brochures, consultation, and the office staff comments. No one tried to talk her out of this. In the decade preceding this one, there was a 62% increase in weight loss surgery in the US. Lap bands went from being almost half of the procedures to less than 1%. Gastric bypass numbers were cut in half as sleeves increased 330% and became the dominant player in the market. The sleeve was initially described as the first of a 2-stage procedure, either a duodenal switch or gastric bypass less than 20 years ago in 2003. And by the end of the decade, it was the most popular bariatric procedure. To date, there have been no randomized controlled trials comparing gastric bypass and sleeve gastrectomy in the United States. Thank goodness for our European and Asian colleagues who have done a few. Furthermore, there are very few physiologic GERD studies in the sleeve population, and what exists is almost all in the first year after surgery. The International Federation for Surgery of Obesity and Metabolic Disorders, the IFSO, last year released a position statement on bariatric surgery, Barrett's, and esophageal cancer risk. They admitted that there was little evidence to guide them, conceded that sleeves were not good for patients with GERD, that caution should be used with these procedures in patients with Barrett's, and concluded that more research was needed. We should add that the vast majority of sleeve patients are within 10 years of their procedure, way too short to know about their cancer risk, even if it were well studied. Let's think about that initial decision. How did that consultation go? What were the questions? What was the experience of the surgeon? What drew that surgeon to the field of bariatrics? Was it primarily a public health directive for an underserved population? Or was it minimally invasive surgery and innovation? Or a job opportunity? I handed over our bariatric surgery program to 2 dedicated weight loss surgeons about 10 years ago, so I am far from an expert. But as I step back, it seems we have been looking for an alternative to gastric bypass for decades. There's the GI bypasses, gastroplasties, lap band, currently the sleeve, and we have a whole set of endoscopic procedures that are bringing our GI brethren into the space. Is this progress? Bypass always seemed like a good operation with a bad name, likely forged by the first few decades of bariatric surgery where they were performed open by low-volume surgeons before it became a real medical field. This is not too dissimilar to the laparoscopic Nissen fundoplication, an operation done too frequently in the 90s with mixed results, then deemed a bad operation by our GI colleagues. Eventually, we gave up arguing and searched for new procedures that were less invasive, didn't we? Let me pause and remind you I am speaking from experience. I carry this talk a decades of guilt. I did notes, research on animals, single incision port surgery in patients, even taught courses. I did TIFs, even injected polymer into the GI junction once upon a time. Hey, now I do poem because I perceived referring docs wanted it, and seemingly everyone else is doing it. I even convinced myself that these new techniques would be better for patients. Maybe poem is better. We just need to do more long-term work to understand it and to get there. There is no doubt I was conflicted, and not just by industry. Let me tell you another story. When I was fresh out of fellowship, two worlds collided. Dr. DeMeester's group declared that paraesophageal hernias should not be approached laparoscopically. That was a big deal in 2000. The SAGES meeting that followed were mixed with anger and disbelief that laparoscopic approaches wouldn't always be better. At this time, mesh was clearly accepted as a solution for most hernias, but there was concern with using synthetic material around the esophagus. A new class of biomaterials were hitting the market, and the possibility of using biologic mesh at the hiatus was an inviting proposition. I had industry willing to support the investigation and the opportunity to work with heroes of the time, Hunter, Swanstrom, Soper. It was an easy decision. However, running a multi-center trial was much harder than I imagined. The industry support was quite modest, and getting busy surgeons to enter their patients and follow-up was difficult. After 2 years, I walked into Dr. Pellegrini's office and said, well, I think we've taken this study as far as we can. I've learned a lot, and I don't think we can enroll 100 plus patients that we need. His response is a lesson for the more senior members of the crowd. He explained that randomized controlled trials were very rare in surgery and were worth the added effort. Importantly, he then picked up the phone and called all the co-investigators and asked them to double their efforts. Admittedly, he had influence I lacked. Everyone agreed, and 2 years later, we completed the study. And thank goodness we did, as the study showed a clear benefit of mesh and a much lower recurrence rate than Dr. DeMeester had suggested. I presented at the American Surgical. People started asking me for my opinion. Lap paraesophageal hernia repair with mesh even received its own CPT code. The effort was worth it. When I presented this work, I always emphasized that the mesh appeared to decrease recurrence in the short term, but we would have to see about the long term. There were doubters for sure, and they were usually senior people. I remember responding to them in my mind like my teenage sons often respond to me. Dad, you're such a boomer. That means old and obsolete for those unaware of the reference. A couple of years go by and our first study patient approaches 5 years. Most surgeons were using mesh by now, but every SAGES meeting, a few people would ask me, hey, when are you going to have your long-term data? I'm so thankful to those colleagues as they fueled my conscience. The follow-up study was harder. Our industry partners had no interest in funding a follow-up study. It was too much risk for them. Yet deep down, everyone knew we couldn't accept just the short-term results. We owed it to our patients to know more. Now, as many of you know, or may be aware, that the follow-up study showed that there was no difference in recurrence rates. Mesh just didn't help in the long run. I remember being embarrassed. How could I tell the world that mesh helped these patients and then come back and say that it didn't? Yet with a little time, this study afforded me more education and pride than few other things in my career. And although it wrecked our nice little treatment paradigm, I think most surgeons appreciated knowing the truth too. Now, I'm not here to argue against innovation. We're here largely as GI surgeons, surgeons that perturb the GI tract's normal state, and short-term success should always follow with a question about the long-term effects, not just pain and short-term recovery. Sure, we can lean on the consent process if we want, but we must recognize our influence in it. When was the last time you had a patient not choose the direction that you thought best, really? So let's get back to the case. An EMR of Mary's nodule revealed a T1B adenocarcinoma with a questionable deep margin. The GI folks suggested ablation and surveillance. This was 2 years ago. Perhaps today we'd do an endoscopic full thickness resection and we'd do something different. But my resident pushed for esophagectomy with colon interposition. She had never seen one before. And this was her chance. I paused. It's a big operation, I say. But there may be positive margins, she says, and there might be lymph node metastasis. We need to be aggressive. She's only 50 years old. I can see this is probably the way to go, but as I reflect further, I think about my patient and the open Nissen. And then I look at my resident. We all have similar motivations, I guess. And while I try to explain my hesitation, the skeptical look on my resident's face screams like that of my kids. Boomer. In the OR, the case goes well. We prepare the colon, the proximal anastomosis is done. It's taken a while. Now the sleeve is just sitting there. One anastomosis, colon to stomach, and we're done. It's a chip shot. But I pause and I reflect on how we got here. How will I prevent reflux into the colon, I ask? Does it even matter? She is 50 after all. Sure, I could do a Roux-en-Y and prevent the reflux, but I'm late for dinner a third time this week. One anastomosis is a lot safer than two, right? And now I am again locked in an existential struggle between what I want and what may be best for the patient. I stayed late. Patient did fine. There was a focus of cancer in that specimen. I suppose it was the right decision, but that's not really the point. Every surgeon in the audience is an innovator or early adopter. And my hope for you is that you struggle for the rest of your career, never confident that you're right. My hubris still rears its ugly head to this day. We should always assume that the patient may want or need something different than our instinct or desire. We owe it to them to search for the best direction in the moment and over time, even if we don't benefit, because in the end, it really doesn't have much to do with us. I'd like to thank you for your attention, and thank you to SAGES for this opportunity to share my story. Good night.
Brant, thank you. And we know you wish you could be here, and we wish you could be here too. And, you know, this has certainly been a tough on everybody. You know, I was listening to your story about the patient with the aspiration pneumonia, and it really resonated to me personally because I had the same experience. I was talked into it early in my career, sick patients, you know, surgery went fine, patient did badly. How has this impacted you over the years in your decision making?
I think that, well, I've thought about her a lot, and I've thought about the situation many, many dozens of times, very specifically when seeing patients. And I got to tell you, I think about it more, I think more deeply every year, and it's cumulative, right? Because there are other similar situations that you experience and then you reflect, and then your reflection, or at least my reflection of the situation, becomes more and more clear. The essence of what was going on there and how I process is almost like, you know, looking at a movie in reverse. And So it has impacted me by pausing in many circumstances, be it in the clinic, be it in the operating room, getting a call late at night from a resident to say, hold on, what's driving you to make this decision? Is it in my self-interest, whatever that self-interest might be, because I want to do the operation, I want to go back to sleep, I want to, get home to see my children, whatever the case may be, and I reflect on that case and many others that I think are in a similar vein, and try to recenter myself and think about what's in the best interest of the patient rather than myself. I got to be honest, I don't think I've done anywhere close to a perfect job in my career, but I felt that it was a good time to tell the story, not only for myself, but because I think the more times I do reflect on that situation, the better decision I tend to make.
Do we have to learn these lessons the hard way? Or does every surgeon have to have one of these unfortunate outcomes? I've sat there with some young attendings about don't operate on malignant bowel obstruction, because it doesn't turn out well. And we have systems where they get paid for productivity. Do you think you've profited from other people's grand advice, or do you think we're stuck with having to, each one of us, learn these lessons the hard way?
I suspect a little bit of both, and I suspect it depends on how much you listen, right? I mean, there are probably people out there who are not listening to this story, and I don't blame them. I mean, who am I to tell people what to do? But that's the reason why we tell the stories, right? That's the reason why you tell the folks around you not to operate on a malignant bowel obstruction, because of the experiences you've had or the experiences you've seen. And I think the more we listen to each other and we learn from the past, it's like, why did you become a history major? Why do they teach history? Is because it's important, right? I think I've learned what to do and not to do from mentors around me. One of the great similar lessons that I recall my mentor, Dr. Pellegrini, telling me and trying to really jam home is he said, every patient's better for 3 months. So what do you mean by that? He said, look, they come to you, if they come to a surgeon, they want to get better. Not all of them, but almost all patients, they want to get better. And you see them, 2 or 3 weeks later, as long as they've had no complications, they're always better. You do an inguinal hernia, you do a lap chole, you do a Nissen fundoplication, I don't care what you did, they're all better in your mind and their mind for about 3 months. So you don't really know anything about their real outcome unless you've seen them years down the line. And you know what? He told me that early on, and it's one of those things that at first I said, I guess I understand what you're saying. And then I saw a patient of mine, a patient of somebody else, and it starts to just like my story. And what I learned, it starts, you see more examples and it resonates back and it becomes more clear to you through your career. So I think you shorten, and we have an ability, if we listen to people around us and their experience, to shorten our learning process. But probably you have to reinforce it, I think, with a few bad examples is the unfortunate truth, probably.
In listening to your story about the mesh, I certainly put my fair share of mesh in for paraesophageal hernia based in part on your study. And so I really appreciate, your reflections, but there's a lot of technology that gets introduced. In the case of putting mesh, it's not a device that is a procedure, whereas with things like links, Barrett, Strata, the device is the procedure, and access to those technologies are controlled by the payers. In the story of the mesh, we control the access to the new procedure. If you were to, sort of find that perfect balance, how would you introduce a new technology at the lower esophageal sphincter, knowing that everything we learned about endocinch, the 1 year data was good, the 2 year data was looking a little worse, and then it fell apart. So, if you could tell the payers what to do, how would you set up new procedures and new technology? Who should do them? Who should get paid for them?
Wow. That's a tough question. Let me give it a shot. Well, I think the biggest problem that we have is we tend to be able to control things in the short run, in the introduction, right? And it tends to be a small group. And part of what I'm speaking to is that I see some of the early access like a club, like everybody wants to get in the club, right? Everybody wants to be one of the first people in line to do a new procedure because there's a lot of exposure, a lot of positive exposure from doing that. So surgeons tend to have some control over that. And then what tends to happen in all the things you're talking about and so many others is if it's terrible, if it's a crash and burn from the beginning, it's done and that's fine. But everyone is motivated, maybe with the exception of the payers, but they can be fairly easily hoodwinked as well to be in the short-term gain. And so if you get 3 months and 6 months maybe data and it looks good and you're not killing anybody, then everybody tends to jump up and down and it's on to whatever the next thing is. And most people just take it at its face value and start doing it. There are always some people in the background, the naysayers, and then it becomes the adopters and the naysayers, and they might quibble for a while. But we're not. If I was to say how to improve upon the situation we have, is we need somehow, be it with the payers, be it with the federal government, be it with the industry, to be more in the camp of being motivated to find out what the long-term outcomes are and really slow down the rapid adoption of these things unless you are willing to be on the long-term train, because it's hard work. I can tell you, it's hard work to follow patients, and nobody really wants to do it. They may say they want to do it, but they don't really want to do the work. So if you're going to be an early adopter and even a midterm adopter, there's got to be a little bit of motivation to, if you're going to do that, you got to be in it for the long run, and you've got to be committed to following your results in a regimented fashion that we can 5 years down the line at least show the world with these devices what the real outcomes are.
It's hard to get paid. It's hard to get paid early, and Lynx is a good example. Many places are still not getting paid. And I've tried to approach some payers of, well, maybe you should pay it on the condition that we collect data or do something, because letting a technology wither and die that might be good is bad, and not, getting rid of a technology, because the trickle was so slow that nobody could see what was happening. The lap band is a perfect example. The reoperation rate was 40% at 5 years. And yet that data was sitting in silos and not even accessible to the FDA. So we really struggle with this. And I think surgeons have a pretty good case of FOMO, fear of missing out. We want to be in, we want to attract patients, and there ought to be a couple of obligations. Notes was a good example. But if you think about what we did with Notes, Brant, we said it's experimental. It was almost a few years later like shooting ourselves in the foot. SAGES said it was experimental, therefore nobody wanted to pay for it. So then we had to do a study to show that it wasn't experimental. And so we're not lined up very well with the payers. And I'm sure you've seen some of this. Do you struggle still to get reimbursed for POM?
Oh, yeah. Very much so. The majority don't pay for it.
And how does that impact, getting back to what you were talking about, in the centerpiece of your talk, knowing that you might have to do a lot of work to get paid, have you ever just sat there and go, maybe I'll just convince the patient to have a Heller door?
That's words right out of my mouth. I mean, and to be clear, I'm one of those who's not sure that poem is better. So it's an easy thing for me to say. But I try to, it's a great example because I try my best to talk to patients with equipoise, and I know that there are many you can see it. There are many places, at least early on, that were doing 90+% of their achalasia operations via POEM for many years. I mean, they really telling patients all that we knew at the time, because I'm not sure they were emphasizing the reflux that you had to know existed. Whether it is something that's a game changer or not, that's another discussion for another day. But it's out there, and I doubt that 95% of people would choose POEM. On the flip side, what I tell people is a nearly equal story, but then I have to tell them, right? I mean, I have to tell them, by the way, if you're thinking about POEM, you got to know that a lot of insurance carriers in our area don't pay for it. So I'm totally happy to do it and go to bat for you and try to make it happen. But it may not work out. And I think sometimes that when I say that last line, they're like, oh, I was 50-50 anyway, or close to it. I don't want to struggle with that. I can't swallow, and I want something done in the next few weeks. I don't want to wait months with this problem. So you're exactly right. We're not aligned. I don't know the answer to get us aligned, because we're in the way the whole healthcare system in the United States is set up is intrinsically set up so that we wouldn't be aligned. That's why most good trials on anything happen outside of the U.S. rather than within the U.S., right? Because there are other healthcare systems where the alignment is better.
And I think that's for sure. And I've really enjoyed listening to your story. It really resonates on so many levels, and it sort of reminds me that sometimes the surgeon is the most conflicted person in the room. And can't thank you enough. Wish you were here, and I'm sure we'll see you next year. Brant, thank you so much.
Thank you. I really appreciate the time and the opportunity.